Emily. I'm a family nurse practitioner student. Today I'm going to be performing a comprehensive head, ears, eyes, nose, and throat and neurological assessment on my patient here. To begin, I'm just going to ask you your name and date of birth.
Maria Gross, 2/13/68.
And I'm also going to ask you for this exam where you are and what the date is today.
I am in Mount Pleasant, Michigan, and today is February 4th, 2026.
Perfect. Just upon looking at this patient, her general appearance is well. I don't see any signs of acute distress, any signs of illness. She appears well groomed. Her mood is appropriate. Her attitude is good. I'm not noticing any signs of any mental illnesses at this time either. So we're gonna go ahead and continue. So first we're gonna start by assessing cranial nerve number 5, which is trigeminal. So to begin this assessment, what I'm gonna have the patient do is clench her jaw. While she's clenching her jaw, I'm gonna be palpating her masseter muscles. So we're gonna clench her jaw, and I'm just pretending to do this. And muscle strength is equal bilaterally. Now I'm going to have the patient relax her jaw and move her jaw from side to side. So go ahead and relax your jaw and just move jaw side to side. And jaw movement is smooth and symmetrical. So now we're going to test sensory by using this Q-tip. So I took a Q-tip and I split it in half. The part of the Q-tip that normally goes in your ear, that's going to be my soft side, and the part that I broke will be my sharp side. And I'm going to rub this on all parts of her trigeminal nerve. So tell me if you feel soft or sharp.
Soft, soft, sharp, sharp, soft, soft, sharp.
Oop.
Oh, that one again. Sharp.
Okay. And sensation is intact and equal bilaterally across all parts of her trigeminal nerve. So now we're going to move on to cranial nerve number 7, which is the facial. So just with any assessment, as this patient sitting in front of me, I'm observing facial features at rest and with movement, but I'm also going to do a quick assessment of some different facial features for her. So first I'm going to have you smile, and let me see you frown, and then show me all your teeth really big, and then I'm going to have you raise your eyebrows, and then I'm going to have you close your eyes really tight, and I'm just going to pretend to do this, but normally I would attempt to open the patient's eyes while they're closed, and her eyes remain shut. So facial movements are symmetric with good strength bilaterally. You can open your eyes. Okay, so now we're going to move on to ears. So normally at this time I would perform an otoscope exam, which I'm going to pretend to do, but obviously I do not have an actual otoscope. So we're pretending it's in my hand, in my left hand. I would go to the patient's side. I'm going to take her pin up and pull it up and back, and then with my hand that has the otoscope, I'm going to turn it upside down. Now I can visualize her tympanic membranes, and upon looking at her tympanic membranes, they're pearly gray, translucent, no visible coning or perforations. So now we're going to move on to cranial nerve number 8, which is acoustic and vestibular cochlear. So for this, we're going to do a whisper test to assess for bilateral hearing acuity. So I'm going to whisper a word in each of your ears, and you're just going to tell me what I said.
Cat.
Yeah.
Dog.
And hearing is intact bilaterally. I would also perform a whine and a Weber test. I obviously don't have either of these instruments as well, but I would do the whine test to compare air conduction to bone conduction, and I would do the Weber test for hearing acuity. So I'm going to pretend to do those. And air conduction is heard louder than bone conduction, and hearing is equal in both ears. So now we're going to move on to eyes, and I'll just start with an external eye exam. So just upon looking at her eyes, I don't see any orbital edema, sagging tissue, lesions, ptosis, any discharge or tearing. Her sclera is white and clear. Now I'm going to move on to cranial nerve number 2, which is the optic. So we would test visual acuity normally by using a Snellen chart. Obviously I don't have a Snellen chart, but if we did, the patient would stand in front of it, tell me which letters she sees with both eyes, and then one eye at a time. Obviously, if there was any issues there, we'd probably refer her to an actual eye doctor to get her eyes checked. I would also do a color discrimination, and that would be assessed as well to make sure there isn't any issues with her seeing any colors. Next, we're going to do a visual fields test. So I'm going to have you keep your shoulders and head looking straight ahead, and with your eyes, you're going to tell me when you can see my fingers coming out of your peripheral. Okay? Yep.
Now? Now? Now?
And visual fields are intact in all 4 quadrants. If, for example, the patient was having a difficult time seeing, or we're expecting thinking there might be a defect, I would have the patient cover one of her eyes. With that eye that's covered, I would take my hand and bring it to the opposite ear. So now we're going to move on to cranial nerve number 2 and 3 and just assess Perla. So obviously with Perla, we're looking to see if her pupils are equal in size, shape, and see what color they are. So just during Perla, her pupils are equal, round, reactive to light and accommodation. I don't have a pen with a light, but I'm just going to pretend this has a light on it. So I would shine this in her pupils. I'm looking for a direct pupillary response in the eye that I'm shining the light in. I'm also observing for a consensual response of a pupillary restriction in the opposite eye. So I'm going to do that in her left eye. I'm going to do that in her right eye, and I do observe that. I'm also going to test for accommodation. So for that, I'm just going to have the patient look at my finger as I bring it towards her nose, and I'm observing for pupil constriction. So I'm just going to bring my finger towards your nose, and you're just going to look at my finger. And I do observe pupil constriction. Okay, so now we're going to move on to cranial nerve number 3, which is the oculomotor, 4, which is the trochlear, and 6, which is the abducens. So for this test, we're going to do what's called an H test. So kind of similar to what we were doing before, you're going to keep your shoulders in front of you, keep your head straight. You're going to follow my finger, but only with your eyes. So don't actually have your head go up and down. And extraocular movements are intact without nystagmus. Now I'm going to have the patient again follow my finger to her nose and test for convergence. And convergence is intact. So now I prepare the patient for an ophthalmoscope exam. Obviously I also don't have one of those, but if I did, I would explain the exam to the patient. I'd also position myself in front of the patient with eye level and her eye level in front of me. I would also adjust the light and then darken the room. For the actual exam itself, I would put the ophthalmoscope in my right hand, and at that time, I would use my right hand to look at her right eye. I would use my left hand to look at her left eye. So we'll pretend I'm gonna look at her right eye, so the ophthalmoscope is in my right hand. For my hand placement on my left hand, I'm gonna put my hand just like this with my thumb right above her eyebrow, making sure there's no pressure on the global or that I'm pulling her eyelid, and I'm gonna absorb all 4 quadrants of her eye. And just upon looking at her eye, there's a present red reflex, normal retinal color, I don't see any lesions, there's normal vasculature, and there's a defined optic disc. So now we're gonna move on to cranial nerve number 1, which is olfactory. So for this one, you would do a nasal patency and sense of smell, and that would be assessed using 2 different scents. I don't have senses, so we're just gonna pretend, but we would do 2 different scents and have her test them in each nostril. So we'll pretend that we would do each nostril, and she's gonna tell me what each different scent is in both nostril. I would also check her sinuses. So for this, I'm just gonna pretend to palpate her frontal and maxillary sinuses. So I'm just pretending to palpate frontal and then maxillary, and there's no tenderness noted. So now we're gonna move on to the mouth and the throat. So for this, I'm just gonna have the patient kind of gently open her mouth. Just kind of gently open your mouth a little bit more so I can see, yeah. I probably have to use a pen with the light just to see a little bit better, but just go ahead and open. Upon looking at her mouth, her buccal mucosa is pink and smooth, there's no lesions, the hard palate is pink and firm, the soft palate is pink and moist, the tongue is pink and smooth, the floor of the mouth is pink and moist, I don't see any lesions or bumps, and then her posterior pharynx is also moist with no red patches or cobblestoning. Her tonsils are grade 0, I don't see any pinkness or anything enlarged. And then as far as her teeth goes, let me just see her teeth. Her teeth appear healthy. I don't see any chipped teeth. I don't see any dentures or retainers. I don't see any crowns. Her gums also appear healthy. I probably put some gloves on and probably assess her gums as well. But I don't see any lesions or ulcers on those. So now we'll move on to cranial nerve number 9, which is the glossopharyngeal, and cranial nerve number 10, which is the vagus. So for this, I would have the patient say, ah, go a little bit bigger. Perfect. So her uvula was midline, and I did observe symmetrical elevation of the soft palate. I also would assess the gag reflex by stimulating the posterior pharynx wall. We won't actually do that. Cranial nerve number 12, which is the hypoglossal. So we'd be inspecting the tongue. So I'm gonna have you just stick your tongue out and then move it side to side. Perfect. So the tongue is symmetric. I'm observing if there are any vacillations or any deviations, which I don't see. Just throughout the exam, her speech is also then clear and she's able to articulate her words just fine. I'm having no issues understanding her. So now we're gonna move on to her neck and shoulders. So first I would palpate her trachea to see if there's midline, if it's midline, so I'm just gonna pretend. And the trachea is midline. I'm also gonna palpate her lymph nodes in her neck and chest region, so starting with the preauricular. So I palpate the preauricular, the posterior auricular, occipital, jugular gastric, superficial cervical, posterior cervical, supracervical, deep cervical, the submental, and the submandibular. And I don't know any lymphedeniopathy. So now we move on to the thyroid. So as the patient swallows, I would palpate her thyroid. So I'll just pretend, go ahead and swallow. And upon palpation, it's symmetrical elevations, and I don't know any nodules. So for the carotid arteries, I don't have my stethoscope with me right now, but we're just gonna pretend. I would put my stethoscope in my ears. As the patient is holding her breath, I'm gonna also take each of her carotid arteries. So you can just pretend you're holding your breath. And I'm also taking both of her arteries, and I'm using the bell part of my stethoscope. And there are no bruits noted. So now we're moving on to cranial nerve number 11, which is the spinal accessory. So first I'm gonna have the patient turn against, I'm gonna place my hand on the patient's jaw and just provide very light resistance and have her turn her head towards the way my hand is. So go ahead and turn your head. Good. Good. And strength is equal and bilateral. I'm also gonna assess her shoulders. I'm gonna just provide, again, some resistance as the patient pushes up. So I'm gonna push down and you're gonna push up. Trapezius strength is intact and bilateral. So now we're gonna move on to the neurological functions. So we're testing her cerebella, her ataxia, and her balance. So this first one, I'm gonna have the patient pat her legs, and as she does that, she's gonna move her hands back and forth each time she pats them. So you're just gonna go like this. Perfect. The next one we're gonna do is have the patient put her hand from my finger as it touches my nose. I'm sorry, she's gonna take her finger and touch her nose to my finger. Okay. This next one we're gonna do, I'm gonna have the patient stand up, and she's gonna run her heel from the inside of her knee, down her shin, to the ankle. So come on over. Okay, go ahead. Heel, down the shin to your ankle, and then heel, down the shin to your ankle. And you can remain standing. We're also gonna do a Romberg test. So for this one, you're just gonna place your feet straight in front of you. Yeah. And then just make sure your hands are at your side. And then when you feel like your balance is ready, you can go ahead and close your eyes. So the patient would hold the stance for at least 20 seconds. So we'll pretend it's been 20 seconds. She didn't wobble back and forth, she didn't fall. So her Romberg test would be negative. You can go ahead and sit back down. So all three of her senses are intact for those. So now we're gonna move on to sensory function. The first we're gonna do is I'm gonna take this fork and she's gonna tell me if she feels sharpness or if it feels dull as I put it at different parts of her. Oh, yeah.
I have thick pants. I'm sorry.
It's okay.
Sharp.
Yep.
Dull. Sharp.
Yep.
Dull.
Okay. I would also do, her vibration sense would also be assessed by using a tuning fork over her bony prominences of her fingers and her great toe. I don't have one of those, but if I did, I would do that. And then I would explain to the patient to tell me when she feels the vibration senses start and stop. Now I'm gonna have the patient close her eyes, and with her eyes closed, she's gonna tell me if she's moving her fingers and her toes up or down. So just like this, you're gonna have your eyes closed, and you're gonna be saying up, down, up, down. So you're just telling me which way your fingers and toes are moving.
Okay. Up, down, up, down, up, down.
Perfect, and all those are intact. So now we're gonna do some more sensory testing. All these will be with her eyes closed. So first we're gonna do stereogenesis. So I'm gonna take familiar objects and just place them in her hands, and while her eyes are closed, she's gonna tell me what she thinks the object is. So go ahead and close your eyes. I'm gonna place an object in my right hand first, and then tell me what you think that is.
Some type of screw.
Yes. Yep. So that first one was a screw. Go ahead and close your eyes. Now we'll do the other hand. Yeah. And then tell me what you think that is.
A block.
Yes. Perfect. So that was intact. Next, we're going to test for graphthesia, and I'm going to take a pen or a blunt object, and I'm going to either draw a letter or a number in her palm. So your first palm, I'm going to draw a number. And make sure your eyes are closed, though, okay? All right. So I'm going to draw that number, and you tell me what that is.
The number 4.
Yeah. And then in this palm, I'm going to draw a letter.
B.
Yes. Capital or lowercase?
Capital.
Perfect. So the next one I'm going to do is the extinction test. So for this, I'm either going to touch her right leg, her left leg, or both legs. So I want you to tell me, or her arms, or any part of her body, but she'll tell me right, left, or both. So just tell me if I'm touching right, left, both.
Okay.
Okay?
Left. Right. Both. Both. Both.
Good. So those three are intact. The last test I'm going to do is for meningeal signs. So I'm going to have the patient stand up, and I'm just going to switch out this chair for a bench so she can lay down. Okay. So you can go ahead and lay down and make sure just your neck is supported. Okay. So for the meningeal signs, we're going to do the Burdinsky test and the Kerning test. So the first test is we're going to do the Burdinsky. I'm observing for the patient to flex her neck, and when her neck is flexed, I'm seeing if her legs are rising. So go ahead and flex your neck. I'm sorry, lift your head up. This, yep. Go ahead and back down. And I didn't note either of her legs rising, so her Burdinsky sign is negative. Next, I'm going to do a Kerning test. So for this one, the patient's going to bring her leg up, and then I'm going to straighten her leg. If she notes any pain along her posterior thigh, there's a possibility that could be a positive Kerning test. So go ahead and bring this leg up, and then is it okay if I straighten it?
Yes.
Okay. Any pain along the back of your thigh with that leg straight?
No.
Good. All right, and let's do the other one. Go ahead and bring it up again. Yeah, I'm going to straighten this one too. Any pain?
No.
So the patient had no pain along her lateral thighs for either leg, so that would be a negative Kerning test. Okay, you can go ahead and sit up. And thank you so much for being my patient, and that is the end of my